Top-Bed Talk.
Natasha Curran is a consultant anaesthetist and pain specialist at UCLH, and her professional course mirrors her talk title in that she's set up a very innovative service in North London and has now been appointed as a Director of Health Innovation South London to roll some of that work out. So thank you very much.
Thank you very much for inviting me to EBPOM. It's great speaking here. And as Mike said, I'm a consultant in anaesthesia and pain medicine. And I thought I'd put my talk into the sort of perioperative quality improvement programme framework because I think that, well, I'm an opportunist, I guess. And when Rami went through the top 5 priorities, she put individualised pain management as the fourth pillar for the year. And it made me reflect about just some simple things and what we're trying to do in perioperative pain management. Well, of course, we want to enhance recovery, we want to reduce length of stay, increase our patient satisfaction, reduce their pain, the side effects of any medications that we might use for that, and of opioids specifically. And also because, as a pain physician, I see a fair amount of chronic post-surgical pain, so it's also an opportunity to look at that. You'd have to have been in a coma to not have noticed this, and Padma has already introduced this, but just to say that this is not a problem just in the States. Again, Padma said 4 out of 5 heroin users started off using prescription opioids. This is now starting to happen in the UK. We've doubled in about 10 years the proportion of UK patients who are being prescribed opioids. And in several kind of year frameworks, we're doubling the deaths from opioid overdoses. Anyone here from Hull? Anyone from Hull in the room? No one from Hull. Hull is currently England's capital of sort of heroin overdose. And again, most of those people started on prescription drugs. And I put this picture up specifically because it's from that website. Obviously, it's a picture from the US. And I just want you to spend a moment just looking at those two people and just being really honest with yourself as you look at those two people and just have a think about what their lives are. Okay? And I put this picture up specifically because it's from that website. Obviously, it's a picture from the US. And I just want you to spend a moment just looking at those two people and just being really honest with yourself as you look at those two people and just have a think about what their lives are. Okay? And I want to do an exercise with you because I'm a pain doctor and you've actually been sitting down for an hour now. So I'd like to ask you to all stand up, please, if you're able. Okay? This is not quite exercise, but it is movement, okay? So you've been thinking about those two people, okay, in the car. Now, I would like you to please sit down if you think there's no way that you could ever be one of those two people. Okay. Okay, and now I'd like you to sit down if you've... hang on, I've got to get this around the right way. I'd like you to sit down. I'm really confused. I'd like to sit down. We'll try it. If I get it wrong, we'll do it the other way around. I'd like you to sit down if you have never prescribed oxycodone in a perioperative setting. I'd like you to remain standing. If you remember that list that Padma put up of all of the things that we should talk to patients about opioids, the long-term side effects, I would like you to remain standing if you do that with your patients. There's very few people standing, so I just want you to remember that. Thank you very much for taking part in that and humouring my indecision. Okay, so that's the exercise. Now, what happens to our prescribed opioids? And I say our because this is just one little study, okay? It speaks to what Padma's study was about in her own hospital. 266 patients discharged with immediate release opioid. Half of those patients, it was newly prescribed. Okay? And more than 4/5 of those, there was no reference to the opioid in the discharge summary to the GP. What do you think the patient thought was supposed to happen? What do you think the GP thought was supposed to happen? 12 months later, 1/3 of those patients had more opioid from their GP. That may or may not have been appropriate. I don't know. 10% of them were still on the opioid a year later on a repeat prescription from their GP. And on the right-hand side, this picture of the United Kingdom, this is a paper which maps opioid prescription by clinical commissioning group to the socioeconomic status of the population. and there's a direct correlation. So our opioids are not necessarily going towards things that we might be doing, and that's kind of obvious that many opioids are diverted, but it's something that we do need to pay attention to. So now I want to remind you again about those two people that I asked you to have a think about, whether that could be you. So I don't know whether you recognise this person. Anyone hands up if you recognise this man. So I recommend that you spend 10 minutes of your life listening to this top med talk by Paul, who spoke on this stage. He's sitting there, 2 speakers before me, because this can happen to any of us, okay? And so in conversation with Desiree and Monty, I highly recommend it for you personally, for your patients, and for your colleagues. What conversation are you having with your patients about opioids before you give them? I think there's also danger that we go the other way, that opioids get demonised and we don't give them when they should be. It's not a black and white thing. It's about informed consent and an educated population. I know 2 friends that have had oxycodone perioperatively, and they both wanted it taken off them at the end of it. They loved it, and they wanted it to be taken away. Paul also taught us that you're going to have 9 operations probably in your life. Just something to think about. Okay. I hope that this is not news to most of you. This is multimodal analgesia. I think we know about the central acting things. That's the opioids, the alpha agonists, clonidine. And we do things like paracetamol non-steroidals usually well. But again, I refer to that thing that Pablo said. Patients don't necessarily know how good a non-steroidal is. People are still scared of it. In our hospital, only 2/3 of the patients that can have non-steroidals get them, and then only 1/3 of those actually get given them by the nursing staff. Terrible, okay? So there's a great opportunity there. The other great opportunity, I think, is in this area, the patient, the experience. You know yourself that the context in which you have pain determines how you feel about it. If a patient expects to have pain and thinks it's a normal part of the healing or surgical process, they just get on with it. If a patient thinks that pain means that the surgeon did something wrong, they're bleeding inside, they're going to die, it changes how they act and their outcome. And we will only know what patients' fears are if we ask them. Unless we ask them, we don't know what their fears are, their beliefs are. We don't know how to modify their expectations. And then we can educate them. We can do interventions like cognitive behavioural therapy, mindfulness, things that work on their anxiety around surgery. Just that conversation, making a plan with them, can be so helpful. And never forget your own effects. As physicians, we underestimate this. Our placebo effect, how we give those medications, by our warmth, our attention, our confidence, is a much greater effect size than the drug itself. So you are your own best drug, okay? So I go through some of these because people ask me to go through some of the evidence, but I expect that some of you know this already. I'm not trying to patronise anyone by these. Ketamine, there is pretty good evidence that sub-anaesthetic doses of ketamine reduces the amount of perioperative opioid you need, reduces the amount of post-operative nausea and vomiting, and the amount of PCA consumption that all patients need. It's a bit equivocal about whether it actually reduces pain intensity, but the benefits in terms of reduction of the other drugs are clear. And that's just one example of one of the studies. There are loads that you can find. It is probably one of the only drugs as well that's been shown to reduce the incidence of chronic post-surgical pain. It's not that I think that perhaps other drugs don't reduce chronic post-surgical pain, but there's not an evidence base to say that yet. The clearest thing is, though, that if we treat acute pain well, we will reduce chronic post-surgical pain. So, from ketamine, how do you do it, okay? So I'm a pretty simple soul. I do little operations, medium-sized operations, and big operations. I always give it to patients that are at risk of or have neuropathic pain and who are long-term opiate use. But for little operations, I give a little bit. So day case gynecology, all my ladies get 10 or 20 milligrams of ketamine. And they go home, no problems at all. If it's a medium-sized operation, I give a bit more, so probably double that if they're having a hysterectomy or something. If it's a longer operation, I start off with a bolus dose. I give a higher dose for the first hour, and then I tail it off to the end of the operation. The only time I've ever had a patient have a problem with this, of course she had to be a recovery nurse, was when she was woken up after the first hour because we couldn't proceed with the planned surgery. I mean, in terms of side effects, hallucinations from ketamine. So lidocaine, this study now is about, 3 years old, But to my knowledge, it's the most comprehensive review of 45 RCTs. The studies in it aren't great, and it wasn't powered to look at safety, but it shows no adverse events. And it definitely shows that it has an early effect on early post-operative pain, reduces the amount of opioids and length of stay of patients, and importantly improves bowel function. So there's been shown sort of disproportionate benefit in abdominal surgery. How to give lidocaine? I think you've got to think about your population. Give it to people who have high risk of pain or ileus, or when a regional is not possible. This is very personal, but I think one of the important things is about how we give it, or the context, because in our pain management centre at UCLH, we give maybe 10 infusions of lidocaine every single day, and have done for 30 years without a problem. And last year, in our intensive care unit, we had a critical incident where the patient had hypoxic brain injury. So that was from a lidocaine infusion. The patient became toxic and it wasn't recognised. So even though we're in a much higher acuity environment, our pain management centre is Padma today. It's like in a community setting. You know, it's far away from a resource team. But even in a high-intensity environment, if nurses don't know about the early signs, for example, of toxicity, they're not going to know how to treat it. And all the other things, I think, are pretty standard. Always to be cautious in patients who are already acidotic, hypoxic, and of course your anaesthetised patients can't tell you about tingling, and you might not notice them fitting either. People ask me about gabapentin and pregabalin. There are lots of trials out there, various doses, different surgeries. There's not enough of a good enough evidence base yet. I said to always use it. I think it depends on context. If I'm having a day case procedure, and have to walk down 3 flights of stairs, I don't particularly want to take one of those. But if I'm having a laparotomy and you can't give me an epidural, yes, please. Okay. I also think it works via anxiolysis. So pregabalin, for example, is licensed for the treatment of generalised anxiety disorder. And pain and anxiety are inextricably linked. They're confounders for each other, and if you reduce anxiety related to pain, you reduce pain. So it's a good thing to reduce anxiety around pain because it reduces pain. Okay. Magnesium and Clonazine. Magnesium, obviously, a good candidate given its mechanism of action to reduce pain like ketamine. Again, the evidence isn't there to show that we should be giving it in every single case yet, one might add. And Clonazine, again, has side effects which may be limiting. So I use both of these things if I'm particularly worried about pain or chronic post-surgical pain in a patient, but not routinely. I want to now give you some lessons from the other side, from being in the pain clinic, seeing patients with chronic post-surgical pain. So this isn't evidence-based, this is just some things that I hear a lot. I woke up in recovery in agony, and it never really went away. Hear that one quite a lot. I felt like I wasn't really believed, that I was making a big fuss, or that the staff thought I was just after more painkillers, and they weren't necessary. Not being believed. People thinking I'm drug-seeking. The surgeon never told me that I would end up with this pain. I would never have had the operation if I'd known that was a possibility. So poor expectations, or not being set well, or not remembering, or consenting. And after the operation, I got an infection, hematoma. It was really painful. I had to go back to theatre a couple of times, and I left in quite a lot of pain. So another theme then about a lot of uncontrolled pain. So with my experience in the pain clinic and from acute evidence bases is, what do I do as a pain anaesthetist? I ask people about what they think about pain, what they're expecting post-operatively, what their fears might be around pain. I listen to their answers, and then I help to reframe their expectations. I explain about analgesia and the trade-offs. Of course, this takes time. Okay, so I guess I invest in that. If patients of mine, or if I see a patient very preoperatively, if you like, if they're on high-dose opioids, I reduce them, telling the patient about how they will have more bandwidth whilst they're an inpatient, and that will be helpful for them. And it's amazing when you see patients do that, because it makes such a difference for them. And if you can get the pain management in there at the same time, that's even better. I signpost them to things to work on anxiety. You can teach a patient breathing techniques in 5 minutes on a ward. All the pain team in our hospital now just do that as a routine for patients in any kind of setting. I'll suggest to a patient to go on a mindfulness course or something like that. In the anaesthetic room, again, this takes no extra time because you're there. The use of healing language. I talk about the positive things that I see on the monitor. If they've got a heart rate of 120, I don't say that. I talk about their nice blood pressure, their oxygen saturation is great. I know this sounds kind of like corny or just kind of obvious, but these things, they make a difference. I talk about the nice nurse that will be looking after them in the recovery, who will help them to be comfortable and help with any other symptoms. La-di-da-di-da. I think you can understand what that might mean. So, regional technique every time if possible, or make a plan if you can't, and or for when the regional wears off. That's the other thing I hear in the pain clinic, by the way. Oh, I had this lovely block which worked for ages, shoulder surgery particularly I'm thinking of, but then I woke up in the middle of the night when it had worn off and it was awful. Because of the anxiety thing, I use Midazolam virtually for all of my patients. I think it's really helpful. I talked about ketamine. Lidocaine, again, there's a bit more, slightly bigger surgery. Clonazine and magnesium if high risk. And the other thing I do is I set an expectation of when any opioids should be stopped, knowing that I might not see that patient just before they get discharged. Our pain team, for patients that they see, writes specific letters to the GP about when to stop opioids and tells the patient as well. If one of my patients is in severe pain in recovery, it's a bit embarrassing. I'm a pain doctor, right? So it's kind of like, I could creep in there. But actually, I know the most important thing is to listen to that person's experience and to validate it. Because if not, they feel like one of those not believed people, and that increases the pain experience and worsens the outcome. And then, of course, you've got to act. So I use my placebo effect as best I can. I'm giving anything that I feel is necessary with warmth, attention and confidence. Where I work, after an epidural bolus or morphine, we give ketamine, midazolam, be mindful of the airway, and clonazine. Now I want to move on to sort of more population stuff. Which is more memorable? A lifetime with your general practitioner, outpatients with someone like me, or surgery. Everyone at this meeting has spoken about the perioperative opportunity to impact on our patients on a number of different levels. I think we can operate, rather than just as anaesthetists, as a perioperative system that helps patients with pain and other symptoms. So we need to identify those patients at pre-assessment who are at risk of severe post-operative pain and opioid addiction, or both. At Duke, you heard Pamela talk about using the pain catastrophizing scale. A screening question that they use is, have you ever used medicines not as they are prescribed? I think that's a lovely way of just sort of seeing how compliant or not, or how the patient's propensity to potentially misuse medicines. At UCLH, we asked patients about previous difficulty with pain in hospital, long-term opioids, a chronic pain diagnosis. We looked to see if their procedure might make them high risk for neuropathic pain, and if they've got any, if they self-report any anxiety regarding post-operative pain. And then we've moved from perioperative team to population health. It ain't rocket science, I don't think, to make a pain plan, just as Paul was talking about making a nutrition plan. But how often do we do it? At my hospital, a brilliant perioperative fellow noticed in the intensive care unit that some of the patients that were staying there were on lots of pain medications. So he went, I know what I'm going to do. I'm going to see those patients preoperatively. I'm going to get one of the pain people to come and see them, make a plan. And guess what? He did that, and he tracked the progress, and it reduced their length of stay, not just in the ICU, but in the hospital. You heard about Padma's brilliant decision to operate to 90-day post-operative pain service. Getting a whole team involved. I'm very lucky in the fact that I instituted a pain management team, so physiotherapist, psychologist, nurse specialist and pain doctor, working with our complex inpatients, not just perioperative ones. But we didn't always have that, and we have only just started to move into the perioperative arena. But our NELA patients, our emergency laparotomy patients, we saw an opportunity to work with the surgeon, pain nurse consultant, surgeon and clinical pharmacology registrar to work specifically with these patients to see whether we could improve their outcomes. And having a method, I think, is, you don't know where you've travelled to unless you know where you started. So using QI methodology, protocols and processes, and mapping that to relevant local and national outcomes. I'll stop there. I'm sorry, Chair. I think I've been over. I'll just leave you with a provocation. I always ask myself this question: what will I do, or will I do anything differently? Thank you very much.
Top Med Talk. Thanks for downloading Top Med Talk. Let me just mention to you, EBPOM Dingle. From October the 7th through till the 9th, The 22nd Current Controversies in Anaesthesia and Perioperative Medicine and SIAA Autumn Congress will be live from Dingle Island, where it will be streamed around the world right to your home. EBPOM Dingle has a certain flavour about it. It's one of the conferences you'll have frequently heard guests and contributors on Top Med Talk referred to in hallowed terms. This is an incredible opportunity for you to be able to go there and enjoy every aspect of EBPOM Dingle that makes it so special. We've got the socialising covered, we've got all of the latest and greatest information, and we've got all of the fun you expect from an EBPOM conference. Check out ebpom.org, and I'll see you there.